Okay, welcome to Spine Conference. Today's discussion will be costotransversectomy approach for a T12 fracture in an osteoporotic patient. So, who thinks Michael Phelps is going to win a gold medal in Rio? Okay, how about who thinks he's going to get Zika virus? All right, just horsing around. No, he's clean now. He's good. Okay, so I like to do case-based learning. So we're going to go over this case. This is not the patient herself, but it looks a little bit like her. It's a 78-year-old woman who her chief complaint was paraparesis. Basically, she could not move her legs. She fell 2 weeks preoperatively, and she went to the ER back and forth. How many times, Aaron? Like twice? Yeah, with pain. Finally, she was admitted, and she just was unable to walk. So her baseline was she was a home ambulator with a walker, but she was independent. She would just basically walk around the house by herself. She lived with her family, and she was pretty independent with her ambulatory status. But in the last week, she could not walk at all, and her legs were weak. So her past medical history is she has a spinal fracture. Her past medical history is significant for Alzheimer's and Parkinson's, diabetes, and coronary heart disease. So neurologically, she's pretty handicapped. The Parkinson's and the Alzheimer's is a very bad combination. But having said that, she still was ambulatory prior to this fall. So anybody want to know any history? Any other history before we go on? Okay. So on exam, she had no rectal tone. How about sensation? She had no sensation. She had, but no rectal tone, and she had loss of her bowel and bladder control, which was new. She did have diffuse weakness of her extremities, 2 out of 4, 2 out of 5. So by definition, 5 out of 5 is complete strength, 4 out of 5 is mild loss of weakness, 3 out of 5 is you have full range of motion against gravity, 2 out of 5 is you have range of motion, but you cannot do full range of motion with gravity. 1 out of 5 is just a flicker. So she was 2 out of 5. So she could basically move her joints some, but not full range of motion against gravity. So the basic, do you know what muscle you need to walk? Which the key determinant for walking? What muscle, Aaron? Do you know? Quads, yeah. So if you don't have quads, you can't walk. But you can, all the other ones you can make do without. So, the big thing is she probably didn't have quads, but she was just grossly weak. And she was right weaker than left, and she was unable to ambulate. So this is her X-ray. This is AP view on the left, lateral on the right. What do you see here, Aaron? So you guys can see the very top, T12, has a fracture. And good morning. And the rest of the spine is pretty normal appearing, some calcium in the aorta. So the vast majority of people with compression fractures, 78 years old with fractures like this, Aaron, how do we treat them? Like what? Yeah, so 96% of the people are fine with just a brace and pain medicine. Just give it a little time, it heals. It heals a little bit crooked, but no big deal. Some of the patients go on to kyphoplasty, right, when you stick cement in the spine. But this patient was different as she couldn't walk. So what's the next step? MRI, yeah. Usually CAT scan in the ER, but MRI. So here's her sagittal cut MRI. On the left is the T2 weighted image. On the right is a fat suppression image, T1 fat suppression image. And what do you see, Aaron? Yeah, it's compressing the spinal cord, right? Can you show everybody, Aaron? Do you mind? If you like the exercise, show everybody where the spinal cord is. Yeah, yeah, and the pressure on it. Yeah, and Why does I showed I put on the fat suppression image just to show you how the vertebral body really lights up on the fat suppression image. See that? So in this case, it's an obvious fracture, but in cases that are not so obvious, the fat suppression image really shows you the edema of the vertebral body where there's a fracture. So it's the best study, I think, for osteoporosis fractures. And so anything else you want to show? So where's the conus end? The end of this end of the spinal cord is called the conus. Where's the conus end? So is that a typical place to end? The L1, L2? Yeah, 85%. Yeah, 85% is L1, L2. Some are L2, L3. Some are a little higher, T12, L1. Okay. So, okay, that's good. Thanks, Aaron. And what do you see on the axial cut? Yeah, why not? Great picture, like great picture. So it's not a great picture. Explain why isn't it a good picture? Is it too bright? Is it too blurry? Right? Yeah. So there's motion artifacts. So she was moving in the scanner, which is quite common because it's hard to lay still when you have a fracture. Okay. So here's the CAT scan, and what do you see on the CAT scan on the axial cut, the same level? Okay. So the yellow dot. Can you guess what the yellow dot is? What's the yellow dot showing? Hmm? So the yellow dot is a cartoon depiction of the compromise of the spinal canal. So the spinal canal is a circle. Yeah, you see that thing? What is that? Yeah, so bone. So that's retropulsion of bone. Basically, the bone went backwards, compressing the spinal cord, and that's the circle that you see in the cartoon is the area for the spinal cord, and the line is where the bone goes. So in trauma, you say space available for the cord. I mean, maybe give it a percentage. So what percentage, just a ballpark, what percentage would you say that is? Yeah, maybe like 40%. Yeah. So the rest, so it's not severe. Like, you can see burst fractures or other fractures where 90% of the spinal canal is compressed. So it's not that bad, really, but it's present. And the other interesting part of this CAT scan is the pedicles. Can you show everybody where the pedicles are? The pedicles are not splayed open. So it's not truly a burst fracture. A true burst fracture, usually the pedicles usually splay open. Although the middle column is, we'll go over what a burst fracture. The middle column is involved. Okay, so here's what do you think? We'll show everybody where that piece is compressing the spinal cord. Yeah, there. So you have that piece compressing the spinal cord, causing its stenosis. A little bit of kyphosis. Okay, that's good. So here's a coronal section. It's a very compressed, right? Compressed and comminuted. So let's go over problems. Like what's the main problem? You think? Yeah, yeah. So neurological compromise, right? And it's probably due to almost definitely due to this fracture because prior to the fracture she was fine. So what do we do? Surgery versus no surgery. Give it some time, see if she gets better. Yeah, she's progressively gotten worse. She can't ambulate, and then over time, if you don't walk, you get whatever pneumonia, blood clot, etc. So this is the typical treatment for a fracture that's neurologically intact. Is a Jewett brace. So it puts 3 points of pressure on the body of the sternum and below on the pubis and in the back of the lumbar spine. Because if you look at the MRI, the natural tendency is for things to compress forward. So your body kind of compress forwards and become kyphotic. So that stops it. You see how that stops you from going backwards? Those 3 points. But functionally, what has been your experience with Jewett braces? They hate them. So the only person that tolerates the Jewett braces are kids. And kids and exceptional people in their 60s, 70s. They both have to be thin, alert, motivated, everything. They just don't tolerate it. And then the orthoists, they have these other Jewett braces that they say are better tolerated. They don't do a thing. I mean, basically, for it to work, you have to put pressure on it, and it breaks down the skin. It's like it's a real problem. Okay, so any questions so far? So that's a typical, and you let the fracture heal. Once the fracture heals, patients are fine. So this is the three-column model of Denis that was, I think, 1983. So this is, who needs surgery? Somebody who has three columns of involvement needs surgery. So Denis broke the spine into different columns: the anterior column, the front column. So that's the most. Good morning. The anterior column is involved in what? Compression fractures, right? With just the front of the spine. If the middle column, the posterior half is involved, and the middle and the posterior cortex is involved, which is involved in our woman, that's a two-column injury. And then the posterior column is the third, which is the lamina, the facets, and the posterior ligamentous complex. So if you have all three, it's an unstable injury, and it needs a surgery. And it makes, if you think about it, it makes sense because there's a spinal cord and nerves in the middle. And if all the whole area of the spine is not working, things slide around a lot, and you'll injure your spinal cord, and also it won't heal. So it's kind of like it makes sense. Okay. So different types. On the top left is just a compression is the anterior column. You can have an osteoporotic burst fracture, but the posterior column is intact. And these are all the different types of fractures. I won't get into them. So again, we just said one or two columns are usually reasonably stable, but three columns are definitely unstable, and they need surgery. The other thing is if you have a neurological injury, it's a lot. You probably need surgery because it tells you. Can you think of an intuitive reason why if someone needs surgery if they had a neurological injury? Like, I think personally, my opinion is it gives you an idea of the level of the injury. Like if someone was struck, like in orthopedics, when someone comes in with a broken bone, we have to know how it happened, like the mechanism of injury. So it's a lot different if someone slips and falls in their kitchen versus they're hit by a truck. Because at the time, if you could take a snapshot of the spine at the time that the truck hit the spine, it would be way, way deformed. And if you can imagine that, that's a much bigger problem than if someone just fell down the steps because the level of comminution and the level of injury, everything is broken. So that tells you something. So mechanism of injury is very important. So if someone has a neurological injury, well, the mechanism probably was a lot worse than what you think just from the radiological images. Does that make sense? So that's the whole point of that. So the other issue you have in the spine is like when you fix it, how far up and down do you have to go? You see that the one vertebral body is broken. There's a short segment and a long segment, and there's a it's to put more screws. It's a stronger fixation, but yet it's more surgery. So you don't want to do it unless you have to. And I think of these spine fractures as I think in the terms of external fixator. Is you could see there it's intuitive that if you just have two pins, it probably won't hold the femur. But if you have four pins, it controls in different planes. And then if you also add another pin in another direction, 90 degrees, then it's even more stable. So the more levels up, the stronger the fixation. So basically, in the very unstable spines, you basically need 4 points above, 4 points below. So another interesting article is McCormick's article. I think it is in 1994, where he studied patients whose screws broke after burst fractures, and he made a classification that will predict a screw will break if you have a short segment construct. So he just looked at comminution. 30% gets a 1, 30 to 60 gets a 2, greater than 60 gets a 3. Distraction of the fragments on the axial cuts. So minimal separation gets a 1. 2 millimeters over 50%, less than 50% gets a 2, and greater than 2 millimeters, greater than 50% gets a 3. And then kyphosis reduction, so how crooked it is, and when you reduce it, what's the change in the kyphosis? So how crooked is an injury? If it's 3 degrees, 4 to 9 degrees, or 10 degrees, 1 to 3. And if you get a 7 out of all these, you need 4 points above and below. If you get less than 7, you can just rely on the integrity of the spine. You can just put 2 screws above, 2 screws below. The newest classification for spine fractures now is TLICS, described by Vaccaro, and the classification system is with morphology, if it's compression, burst fracture, translation, rotation, distraction, neurological injury, and the posterior ligamentous complex. So this is just a way that it's a research tool, and if it's a way that you can think, um, if you're not sure whether you do surgery or not, you can rely on this study. But basically, if you have a neurological injury and the posterior, if you have a fracture and posteriorly it's unstable, those people need surgery. So you could just break it down like that. So the other thing is what kind of surgery if you have a fracture of the spine. So this thing, you see that big fragment in the spinal canal? This thing needs an anterior approach. It's really hard to get this out from a posterior approach because the nerves are in the way. So you see the spinal canal, this thing's in your spinal canal. And the only way to get it really is to go through the side to lift this thing out. The nerves all the nerves are splayed around it. It's very hard to get this from a posterior approach. So when you have these very large fragments that are compressing the spinal canal, you have to go through the front of the body. The problem is going through the front of the body is a problem because you have to either go through the abdomen or the chest. And it's definitely doable, but it has a lot of morbidity. So the typical for a thoracic burst fracture is you have to go through the chest. You have to cut over the rib, then remove the rib, and then once you remove the rib and you open the chest, you see the segmental vessels, and you're looking right at the vertebral body, and you can very easily remove it, and then look at the thecal sac. And this is just, and then if you go through the chest, you can insert something in the front, either a piece of femur or a piece of metal like a cage, interbody device, and then a plate and screws. So going through the chest. So when I first saw this patient, I thought to myself, I have to decompress the spinal cord, and it's the only way, the simplest way to do is go through the chest. But in a 78-year-old, what's going to happen if you go through her chest? Yeah, she's not going to do well. What do you think, David, going through you have any experience with that, like giving someone that age a thoracotomy? Yeah, almost guaranteed. It's hard to take a deep breath. Um, has anybody here had a rib fracture? No one's here has a rib fracture? I'm surprised. That there's a wild bunch. I would think a couple of people would have a rib fracture. So I've had a rib fracture. It's very, and that's just a little crack. It's really hard to breathe with a rib fracture. Um, so you can imagine if you have the rib out, it's even worse. So you can also decompress the spinal cord from a posterior approach. And that's what we're talking about today is on the top is a costotransversectomy approach, and below that is a lateral extracavitary approach. And the difference is basically how much rib you take out and what your angle is. So the bottom one is a lot more of an angle, but you have to take a lot more rib and probably a higher probability of a pneumothorax or hemothorax or an effusion in the chest. So basically, I think it's less morbid to stay out of the chest as much as possible. But they're very similar. You take out the transverse process, the pedicle, and the body. And this is just, again, a general idea of how you can remove the bone compressing the spinal cord from a costotransversectomy approach. You can get a lot more of the body out and get to the other side the more lateral you are. So this gives you an idea of like how much you can get out from just a costotransversectomy approach. That's what you can see. And you can see here that the spine, everyone knows you cannot retract the spinal cord. So you have to completely leave the spinal cord alone. So this gives you an idea of what you can see anteriorly, that is, from this approach. You can't see that much anteriorly. You can only see so much. So, I mean, you can take the whole thing out if you do both sides. But if you do both sides, it's more surgery. But you can do it if you have two surgeons, you can do it. But for me, I don't have that option. It's just I'm by myself. So for me, it'll take me more time. So if you take out both sides, then you totally expose the spinal cord and the nerve roots. And to stick a cage in, like on the left, you have to cut that nerve root. because the nerve root gets in the way. Luckily, in the thoracic spine, um, the thoracic nerve roots really don't have much function other than sensory and some intercostal muscles, so you can cut a thoracic nerve root. Um, so just to give you another idea of the costotransversectomy approach, it's a posterior approach, so you stay out of the chest and you remove the front, and then you can stick an antibody graft in the front. So in this patient, I decided these are my just notes from the surgery. I decided to do this posteriorly shows how much I removed. I severed the nerve, the left T12 nerve, which is right there, and I removed the lamina, most of the lamina of T12, and I resected I took the pressure off the spinal cord with a reverse curette. I pushed all the bone fragments into the chest and then retracted it with a pituitary rongeur. And the first order of business is to remove the pedicle. It's best done with an osteotome because it's really sharp. Then once you remove the posterior cortex and the pedicle, the rest of the case is done with, remember, the large curette and the pituitary, and then the reverse curette to push the fragments away from the spinal cord. Usually, actually, first I use a Penfield 4 to tease it off the spinal cord, then a reverse curette to push the bone fragments into the cavity, and then retract it. And then you remove as much bone as you can. The case took 4 hours, and most of that time was the decompression. Lost 600 cc's of blood. Usually I like to, once you take that whole bone out in the front, there's a defect, there's a hole. I usually like to fill it with femur because it's a natural substance, but it'll be difficult to insert the femur because the spinal cord's in the way and you have to get it just right. So in this case, I used the other problem with the femur is that it can shift once you put it in. So in this case, I used this expandable cage, which the benefit is you get the size just right because you can change the size once you put it in. And also it doesn't shift once you put it in because it has the spikes on it. So those are the two basic reasons I use the expandable cage in the front. So this just gives you an idea. Again, 4 points, 4 screws. This is post-op. 4 points above, 4 points below because it's very unstable. And then I inserted this cage in the front to give it strength. And this is the post-op CAT scan. You can see the cage in the front of the spine. And that's basically replacing the vertebral body that I removed that was broken and compressing the spinal cord. So that's a side view and that's a front view. And you can see I was more on one side because with the costotransversectomy approach, unless you go on both sides, you can only remove so much from one side view. And I just felt I could fully decompress the spinal cord from one side. I couldn't take the whole body out, but I don't think I needed to. And I thought that was enough to give the spine strength. But we could have, if you have two surgeons, you can easily remove the entire body. Here's the pedicle screws, just shows the implant pedicle screws, and on the bottom left shows the spinal canal. Do you remember before there was like the fragment here pushing on the spinal cord, and you see it's gone. So by removing all this, I removed everything, pushed it forwards, and then this thing just basically gives strength to the spine post-op. This is another axial view, which shows all the pressure on the spinal cord is gone now. And you can see how much of bone I removed from the spinal canal. See how the spinal canal is wide open here? So the benefits of this approach is that I never had to open the chest. Although she did post-op get, she did have a pleural effusion pre-op, and then post-op it got worse. And I was worried she had a hemothorax. You see here on the bottom one is the pre-op, and you can see and the top left is the post-op. Her left pleural effusion got worse. I think I added some blood to it. Can you see that? Like pre-op, she had blood here, and then it got a bit worse post-op. We just followed it, and then radiology did an ultrasound-guided aspiration, took some of the fluid out. But it wasn't. She did okay post-op, although she did not become ambulatory by the time she went to rehab. I was hoping the next day she would stand up and walk and be normal, but it didn't happen. She didn't want to. She felt her legs were weak. So that's it. Let's see. Is there any questions about costotransversectomy approach? Removing the pressure on the spinal cord through a posterior approach. Brian, you have to have one question. Technical question. Treating this posterior approach? No, you don't have to.
No, I agree with everything that you said. The reasoning for going to finite. I remember interoperatively we were kind of deciding whether or not you had to move from a costotransversectomy to the extracavitary to fit the diameter of cage that you wanted
to go more lateral.
Because we were trying to maximize end plate coverage with the cage. There was a smaller one, but we got a bigger one in there.
That's what I did though.
Yeah.
I just gave myself more space. So you just keep pushing. You just keep pushing down on the lungs and removing more rib until you can get a horizontal view of the body to stick. Let me show you.
Because back to what you said about the 3 columns, it's so important to get that device into the anterior column and not leave it.
Yeah, in the front. I mean, obviously you can't put it in the spinal canal.
No, but sometimes if you undersize the diameter of the cage, you don't fully remove the bone in the anterior third. You end up sticking the cage almost in the posterior half of the body.
Right. Well, I think if I put a smaller cage, it would have been easier for me to put it more anterior. I could position it wherever I wanted. But I used the biggest cage. I used a very big cage.
Right. But the other thing, if you undersize the cage, you get inside the apophyseal ring and you have a thicker inches beside it.
It's better because it's over a larger area, so it's less force where it is. So it's more likely that it's better to put the bigger one in, probably.
I agree.
But you can see that you can see in that, and it's just basically the angles a little bit. So I don't think it's a 1-0 relationship. I think it's a kind of spectrum, a continuum where you go straight posterior versus straight horizontal, and it's just a little bit more.
Right.
You just go more and more and more. So that's what I did in case I took a little more rib.
Right.
I pushed things down a little bit more. I exposed a little bit more, and then I just shoved it in when it was perfect. What else? Any other questions? Yeah. Do you know how she's doing? She did fine post-op. Like, she didn't have any problems. No, she couldn't walk at all. We'll see. We'll see. But at the time, when we made the decision, we kind of had no choice. It was either mom is never going to walk again, or we give her a chance to walk. So, and since mom walked before the injury, they wanted her to keep walking. So the decision was kind of straightforward, I think. Otherwise, she doesn't walk, she's not going to do well at all. Yeah, well, we'll see. Time will tell, I guess. What were you going to ask a question? I usually don't limit anybody in any way because I don't think they do it anyway. And in orthopedics, basically, the goal I think is to fixate it because we have very good fixation techniques now, screws, rods, implants, etc. Is fix it strong enough where people can just do whatever they want. So I don't limit them at all. Almost never. It's different I guess if you fix a femur fracture, you want to tell the person to be partial weight bearing or not weight bearing as much as they can. Otherwise, you're asking for trouble. But it's very difficult to keep people immobile. Is that it? Any other questions? Did anybody learn anything? Aaron, did you learn? What's one thing you learned from the conference? Something new. Oh yeah, yeah. They're good. Do you have any questions about classification systems? When do you think? When do you think? Why do you think I don't use them? Like we didn't even talk about it. Like I didn't even talk to you about it at all.
Because for her,
Not very helpful, right?
Right.
So sometimes classification systems are used for like communication, and sometimes they can be helpful because they're kind of tools. So if you're not sure if you should do something, you go back to the research classification and see what that tool says that you should do. But usually, when you're experienced, the decisions make is pretty clear.
right.
I,
Or
I,
if it was you're not 100% sure it's the right way to go. Someone even if it's family don't know you can make a decision.
I haven't found when you get very technical with people that it helps. Um, they basically just said usually people, I mean human beings, and I do the same exact thing. Say, what would you do if it were your mom? And that's basically what we do. Or what would you do if it were you? Um, the golden rule is like treat everybody like you would treat yourself. Okay, that's it. Thanks for coming. You're welcome.